Good morning, everyone. Welcome again to the Borderline Personality Disorder Education Webinar Series. For those of you who don't know me, my name is Chris Palmer. I'm a psychiatrist here at McLean Hospital. I'm also an assistant professor of psychiatry at Harvard Medical School. It's a pleasure to welcome all of you today. We're joined by John Gunderson, Dr. John Gunderson, to have an open conversation about borderline personality disorder. If you didn't see his prior webinar, that is archived on our existing site. And so today really is a follow-up conversation with Dr. Gunderson about borderline personality disorder, any of your questions, challenging situations you're dealing with, and we will get through as many of them as we can. For those of you who don't know Dr. Gunderson, he is a professor of psychiatry at Harvard Medical School and has devoted his career to the clinical care and research of people affected by borderline personality disorder and also their families. He was instrumental in validating this as a psychiatric diagnosis, really taking it from a vague psychoanalytic construct that it had been. More recently, he has been focused on increasing access to care and increasing competent care for people affected by borderline personality disorder. And he has developed a treatment protocol and training programs called Good Psychiatric Management, which, as opposed to a lot of specialty treatments that you have probably heard about, such as dialectical behavior therapy, mentalization-based treatment, and others, this one is for general mental health professionals. So a general psychiatrist or other mental health professional can take a relatively short training in good psychiatric management and be competent to treat patients with borderline personality disorder. And this treatment has actually been compared to one of the better known specialty treatments, dialectical behavior therapy, and has been found to be just as effective. So he is really a big advocate for increasing access to care and increasing recognition of this diagnosis. We do want this webinar to be as interactive as possible. Many of you have already submitted questions and challenging situations that you want us to ask of Dr. Gunderson, and we will get through as many of those as we can. But for those of you who are joining us live right now, you'll see a Q&A box in the lower right-hand corner of your screen, and please type in as many questions or situations that you'd like help with, and we'll get through as many of them as we can. And now it's my pleasure to welcome to the webinar Dr. Gunderson.
Good morning. Glad to be with you. Hope to make this instructive and even entertaining if I'm lucky. Yeah.
Great. So Dr. Gunderson, as I said, we've got a lot of questions that have already been submitted, and I'm sure we've already got more coming in as we speak. So I will get right to it. The first one is written, my son will get irrational and make horrible accusations or distort or wildly exaggerate the truth. He will often project his negative thoughts or actions on me. How do you think I should respond when he does this?
Well, excuse me, I've got a bit of a sore voice box, but I'm healthy. The first suggestion I'd have is to own as much of what you feel is being projected onto you as you can. So if the person is very angry at you, you look for why there might be a good reason for it, as opposed to responding with that part of it which is unfair and you think projected from themselves. So, for example, if you have been slow in responding and the patient says son says you're ignoring me, you don't say, well, I wasn't ignoring you. That's a defensive response, which will just make your son more angry. But rather is, I'm aware, I was delayed in responding because it's not an easy issue for me to respond to. So you take on that part of this, which might be caused by you, and that usually will diminish somebody's anger and allow a more reasonable conversation to follow.
Okay. We will move on. My 24-year-old son with borderline personality disorder says that when he's depressed, he just can't function. He won't go to therapy when he's depressed, or really do anything at all. His therapist tells him that he can, in fact, function, and has given him skills to do so, or at least recommended skills that might allow him to do so.
Yeah.
How can I help him when he's in this non-functional state?
That's a difficult question to answer without knowing more about your son and also about your relationship with your son. Oftentimes, people with borderline personality disorder come from families where the parents have difficulty setting limits and insisting that the kids do things that they're capable of because they don't want their, in this case your son, to be angry with you. I don't know if that's the case here, but if that was the case, then if your son doesn't want to go without him and take advantage of whatever counseling you can get from his therapist about how you can be more helpful. Take this question up with the therapist. Son doesn't want that. That would be, he could use the time, but you shouldn't, and you become collusive if you waste the time that's allotted for the care of your son by not taking advantage of it yourself. Sometimes the situation is a little different than that, and the son, in this case, your son might be responding to a family atmosphere where he feels like he always has to do what his parents want, and he's sort of getting some legs under himself for standing up. It's not so much about not wanting therapy, but it's about asserting himself. And in that case, your response might be, again, to sort of appreciate that this may be a step towards health, but again, be active in talking with the therapist so that you have an understanding, and again, going to see the therapist in your son's place may be a very good way to manage it.
So let me dive just a little bit deeper into this. So one of the statements in this question or case is that his therapist tells him he can function and has given him skills to do so, and yet those skills aren't working. And I'm wondering how good the alliance is with the therapist. If the son feels like that therapist doesn't get me, that therapist doesn't know what he or she's doing, yeah, they say this stuff is supposed to work, but it's not working.
Yes.
Good. And that might also, it might explain, number one, why it's not working. It also
why he doesn't want to go.
And why he doesn't even bother going to the therapy session.
Absolutely.
And if that's the scenario, what might you recommend?
Well, getting a consultation, for sure. But I'd start by, as the parent in this, talking with your son about that, as to whether there's some issues that are going on between him and the therapist, and hearing his side of that. And if it's a convincing story about alienation or feeling misunderstood, then help your son communicate that to the therapist, see whether anything can be done about it, but otherwise getting a consultation and maybe considering. This sounds when a therapist says that he's given your son skills and he feels he's able to do this, that the therapist may feel that his patient, your son, is willfully not using the skills that he's learned. That can happen for sure. Once again, then you have a question of his not going and why, how much of that has to do with the therapist, how much of it has to do with his relationship to you and family. It's a very important question that you look at from both sides.
Good. No, I think that's very helpful. So the next question. In your borderline personality disorder brief, it says that as individuals with borderline personality disorder get older, the severity of their illness often diminishes, and that 40% of BPD patients remit within 2 years, and that this rate rises to 75% after 6 years. It's not clear to me, though, if these data refer to patients who are in treatment or not in treatment. Is the course of illness the same when a person is in therapy as opposed to when they are not in therapy?
There were 2 longitudinal prospective studies that followed large numbers of borderline patients. One sample came from McLean Hospital. All the patients were hospitalized and received treatment which initiated on our inpatient units and usually had good follow-up, but highly variable follow-up as they went into outpatient care. The other group, the other study, the collaborative longitudinal personality study, which was conducted at McLean, Brown, Yale, and Columbia, involved 19 different clinical sites selected to be representative of the care that patients receive in many, many settings and across all socioeconomic groups. There, the level of care, both initially and during the follow-up, was fairly sparse. Virtually nobody received treatment that was specific for borderline personality disorder. Looked at carefully, one can say that the inpatients from McLean may have done a little bit better than the outpatients from the 4 sites. Now, that's a good thing, working at McLean Hospital, because you start out with what you think might be a sicker population and they're doing maybe a bit better. You'd like to say, well, that's a treatment effect. The larger generalization is that the patients in both studies did about the same. And that that's a suggestion that the natural course of this disorder was determining these remission rates more than it was treatment. And certainly it never depended, these results in either study did not depend upon getting extended care by borderline experts with empirically validated treatments. So I think those results are quite trustworthy. What those results don't say is that in both studies, the symptoms went down, but the remission was not as clear in their functional capacities. So people stopped using hospitals, they stopped cutting themselves, they became less depressed, but not very many of them developed satisfactory partnerships or satisfactory work lives. One other note, I believe our current treatments are addressing these social adaptation things better than the treatments that were done at that time. And when borderline patients remitted, and this is in some ways the most encouraging part of it, it was more slow than something like major depression. But when they remitted, 85-90% of the time they stayed remitted. And that's a very positive and powerful clinical message.
Good. The next question. I think one reason borderline patients have a hard time maintaining relationships is that they seem so incredibly self-centered. When I talk to my daughter, I go to great lengths to try to remember what she has told me about her activities, and then I try to ask her about them. I even keep a notebook for this purpose. But she never asks how I am or shows the slightest interest in any of my activities. Neither does she ask about her father or any of her siblings.
Yes.
She just doesn't seem to care at all, although I'm sure at some level she does care about us. Is there a way for me to suggest that it would be nice for her to show some level of caring about other people without seeming to criticize her?
Well, there may be some reciprocity here in that you're so careful about not wanting to criticize her, and you're so careful in trying to chronicle and remember everything she says. You may have contributed to the development of this self-centeredness. You're a person, everybody in your family is a person. You might not realistically expect reciprocity, but you should not ignore the lack of it. People with borderline personality disorder can become very self-centered for a variety of reasons. Not only or necessarily because they're so narcissistically self-absorbed, but because they feel so lousy or they feel so bad about themselves that they don't like to disclose much, because they are trying to distance themselves actively from people that they care too much about. It would be very unusual for somebody with borderline personality disorder to not care about what their mother, father, and siblings think. It is not so rare for them to feign indifference and to knowingly even punish you by seeming to show such little regard. I would be very active in saying it hurts your feelings. Not being angry about it. You might feel angry, and there may be good reason, but that's not a very good stance to take. A strategic stance is to talk about how it hurts your feelings that she shows so little interest in you. And you feel, I also add, I feel a little worried that I'm so careful not to offend and hurt you that I may be encouraging you to have unrealistic expectations of what you can expect in relationships. Those are both good statements, starting with yourself, that you're worried about the way you're managing the relationship with her, and that it hurts your feelings, as it does her father's, that she seems so disinterested in you.
No, I really like that because it puts it on the person to almost implicitly say, I care about you, and I notice that you don't seem to care about me, and that hurts me. And in a way, I think it could almost be seen as a plea of letting somebody with borderline personality disorder know how important they are, how much you do care about them. You actually care so much that you notice when she doesn't say anything. And so I really like that.
It would be very nice if your daughter is in a therapy to encourage some type of family meetings in which these issues can be openly discussed, and certainly so that the therapist is aware of this aspect of her behavior, because what she's doing with you, if this translated into the way she treats other people, is going to assure that she's going to have a very lonely life, and it certainly is not good for her.
So this next question is a challenge I already know. So anytime that I try and assert my authority, my son flips out. He can't hear a firm no and be okay with it. He always fights with me and never seems to understand that as a parent, I am in charge. How do I set boundaries and get him to abide by my rules?
Well,
I knew you would like that.
Well, first of all, you're not really as in charge as you might hope. The control struggles can get very serious and can be very destructive between parents and children in general, but with borderline sons and daughters, it can often result in alienation and self-destructive behaviors or even violence. So you need to address this not as an issue of your sons needing to learn how to be compliant with your authority. That strategy and wanting help with that is not going to work. What you can hope to do is get into a discussion about who's in control of what, and a therapist can do that, but it's got to start with you. That is, you cannot assume that your son should comply with you because of your authority. That may be the way you were raised. It's a model of parenting. It's not a very productive one if your son or daughter has borderline personality disorder. It's just going to aggravate the problem. So you have to start out by coming to terms with the fact that what you can control is limited, and how much authority you have is limited, and that it is unrealistic to expect compliance, obedience, and respect. That's something that may be developed, but by no means can be assumed.
Yeah. As the father of a son, I can relate to that.
Yeah. As a father of a son and a daughter, I learned that,
The next question I'm going to pose from one that's just been submitted. We have several other questions we can get to that have been pre-submitted, but I want to go to some of the questions that people are typing in right now. So this person says, my daughter has had frequent suicide attempts. It's been going on for several years, and I'm at a loss for how to get on with my own life in the face of these constant acute crises. It seems heartless for me to try to go on, but I don't see what else I can do. Do you have any advice for parents?
Well, this is a complex situation about which it's hard to say anything with certainty. It is not healthy for your daughter or for yourself or your family to feel held hostage by the threat that your daughter can and might kill herself on account of your behaviors or feelings, or when this happens, one of the guidelines is that you need to transfer the responsibility for your daughter's safety into the hands of professionals. And that if there's a crisis that arises, it doesn't end up being something that you feel you have to manage alone. You want to consult with a professional, ideally to have in this case, your daughter, talk to the professional herself. That becomes the buffer, that becomes the first line of intervention. Decisions about whether to go to the emergency room or a hospital are things which at that point involve a professional and don't depend simply on your behavior. If you over-respond to the threat of these crises, it can become habit forming, that your daughter expects that if she says she feels suicidal, she'll go to an emergency room, family will gather, wring their hands, and she's got a lot of power there to control the family and to get, from her point of view, maybe it's her way of getting assurances that you care about her. But it's a behavioral way, and it's destructive to her welfare and yours. So you want to find other ways to manage her safety, to assure her safety, that is not going to depend upon your preventing her from hurting herself.
So this particular person wrote a little bit of a follow-up that her daughter's been in therapy, including 6 months of residential treatment, so is getting the best therapy available in their area, I'm going to assume. And I guess I'm putting myself in the parents' shoes, and maybe a slightly different question I would want to ask is that my daughter suffers from borderline personality disorder. She complains of being chronically depressed, empty, feels worthless, feels like there's no point in her living. She's worried that she's really just a burden to me and everyone else, and that maybe we would all be better off without her. And for years I've told her, that's not true, I love you to death, I really love you. But here she is, continuing to attempt suicide over and over again, and continuing to report these similar symptoms.
And I gather still living at home under your watchful eye.
And what advice would you give to a parent who has that dilemma, this dilemma of she's gotten all of the help that we can muster, that we can access, and it doesn't seem to be working. She continues to report being depressed, feeling worthless, feeling like there's no point. And I imagine the guilt for the parents is that if they somehow are seemingly going to make their life okay now, if they say something to the daughter like, well, if you do that, it would be heartbreaking to me, but I can't control you. That's not my decision to make, it's your decision to make. And since I don't have control over that decision, I have to go on with my life. I have to develop a life, and it doesn't mean you won't be part of it. It doesn't mean that I love you less. It doesn't mean that I don't love you, but I'm going to move on with my life. But I imagine a parent's fear is that by moving on with your life, it's kind of they might worry that it's a tacit agreement that, yeah, we don't need you in our life anymore. Go ahead and kill yourself.
Well, that's a very complicated
I'm sorry.
situation. One part of it is, has the daughter really received very good treatment? 6 months in a residential stay is a lot of intensive care. It is surprising to me that somebody could leave care like that and still be chronically suicidal and living at home with a parent who feels like her life is shortchanged and essentially preoccupied with the care for this daughter. No part of that is, it can happen, a situation like that can happen, but you got to start out with the idea that this is an extreme and a rare situation. Was that treatment not effective? Was the circumstances that you entered into after leaving the treatment something that was regressive, caused her to go back to a state that she had gotten out of during the course of that treatment? They're as devoted and loving as families can be and maybe feel is necessary when you have the threat of suicide hanging over your head. That kind of devotion can be a interference with a child's getting ahead in their life. It can feed into the sense of hopelessness on the part of the patient, because their parents treat them as if they are helpless and they're hopeless. Why is it that your daughter isn't in school or back in some kind of work? Those are the activities, as much as or more than any ongoing therapy, which give life meaning and set the stage for independence. In isolation, conveying to your daughter that it's her decision and that you have to get on with your life are both good messages. By themselves, however, they're not going to advance things very much. You're getting on with your life, the action of it may help things. You may trigger some suicidal act, which will probably be a gesture, testing, checking out whether you mean it. It'll be very tempting to then come back home, devote yourself full time. And that you need a therapist on the other side of this who's working with your daughter towards getting a life, and aiding you in the idea, in supporting you in the idea that you can't expect, and it's not helpful to you to have your mother devote her life to your safety. It's not a viable situation which is good for either your daughter or for your own life. I said this in the last vignette too. You've got to get out of that where the family, or certainly one person's life, is devoted to the child's safety. It's not, it won't work, it's counterproductive.
Okay. So we're going to move on. So this question was pre-submitted. There are often long waiting lists for specific borderline personality disorder treatment programs such as DBT or MBT. Do you think individuals with BPD can benefit from traditional therapy with a therapist who's not trained to work with BPD? What about regular CBT therapists? Can they be an alternative?
Well, yes. I remind you, the natural course of this disorder is the majority of people get well slowly over time in the absence of any kind of intensive treatment, certainly any treatment involved by experts. The mission that has filled my professional life these last 5-6 years is encouraging clinicians to have a more informed and more optimistic attitude about the course of borderline patients and how they can facilitate recovery, rather than entering into their treatment with borderline patients with the idea that these are intractable disorders where they're going to face lawsuits and non-compliance. Most clinicians, if they're adequately trained, are going to be good enough for most borderline patients. And what good enough means is that you stay within your limits. Once a week is generally fine. That you don't elaborate and expand the care in response to dysfunction. If you get going to see somebody better, it's because they're more frequently, it's because they're responding well and using the therapy. It's a continuation of the treatment should depend on whether the patient is getting better. If the patient's not getting better, then you wonder whether the therapy is useful. So you change the whole paradigm, the whole attitude around which treatment is organized. This has less to do with CBT or psychodynamic or even years of experience. It's an attitude issue. Most clinicians who are experienced with borderline patients, they don't do specialty treatments, but they're going to be good enough for the vast majority of patients. And they need to have had basic training, and they certainly need to understand the genetics of the disorder and the natural course of the disorder. They need not to have some ideas that they're omnipotent, that the patient can and should rely on them for everything. They need to collaborate with patients. They need to insist that the patient collaborate in their own care. It's not given to them, and certainly can't depend on medications alone. Medications can be helpful. But most clinicians, if they help patients get on with their lives and are supportive, good sense, and don't do anything stupid, are going to be sufficient.
Good. The next question again was written in.
I want one footnote on that.
Okay.
There are a group of therapists who generally don't do well. People who are psychoanalytically oriented and try to do psychodynamic or psychoanalytic therapies in the old style, where you follow the patient's lead, you're not active, you're sort of a passive listener. That kind of therapy is generally harmful for borderline patients. They will experience that kind of therapist is not caring. That isn't, of course, the fact. It's just that the experience of borderline patients, when you have a more passive therapist or somebody who, rather than being an active participant who helps them with their life decisions, sits back and sort of helps them examine why their life goes sour when it's led by them, that kind of therapy is often harmful.
Could you elaborate a little bit? In what ways might it be harmful? What might you see that would be the harm?
A person with borderline personality disorder, the therapist is passive. They'll feel that the therapist isn't saying anything because they don't care, or they'll project onto the therapist that the therapist doesn't like me and is angry in the absence of all it takes for the therapist to say, wow, You got to be interactive, you've got to be present, you've got to show the patient that you're listening and responsive. And so that's a major reason why it's harmful. Another way, which is a traditional thinking about borderline patients, therapists used to say, well, I don't want my patient to ever fear abandonment, so I'll make a commitment. I'm going to work with them for as long as it takes. And if they get in more trouble, I'll see them more often. Those are natural instincts from good people who want to be helpful. But for the borderline patient, those messages are that this therapy, the therapist's involvement will get greater if I'm dysfunctional, which is, I'm very ambivalent if I'm borderline about becoming a functional person. I'm frightened that I'll fail and I'll be confronted with rejection. So maybe I don't have to do this, and I get more attention and more affection from my therapist. And that if I'm dysfunctional and if I'm getting worse, very bad messages. Such therapies started at a time when they thought these patients were intractable, and some miracle, intensive, long-term therapy was the only thing that could get them well. What we know now is that you better frame your treatment as, I'll be with you as long as I'm helpful. If I'm not helpful, in other words, if you're not showing some signs of improvement, then we have to question whether this therapy is good. Not all patients get better, but if they're not getting better within the course of the treatment, you need to flag it. That's the exception. The natural course of this disorder is like this. People get better, different rates, but they get better. The patient's getting worse under somebody's care. Flag it. Something's wrong with this.
And so let me ask a question specifically on that. What about the patients who just seem stuck? So we've talked about remission rates, the remission of symptoms, but we've also talked, you've alluded to it, and we've talked in other webinars about recovery rates of actually having a full, active, engaged life, maybe as defined by having full-time employment and a significant relationship with a sexual partner or a romantic partner or at least a good friend. And that those might be two metrics, a significant relationship and full-time employment. And we see so many patients get stuck and they don't get there. And should that be flagged as a treatment that's not effective if a patient is stuck there for a couple of years?
That's a complicated question. The study by Mary Zanarini showed very high rates of recovery, both within satisfactory work and partnerships, occurring increasingly over time. But some of that is still rising at 16 years after the initial study started. So it can take a long time to acquire both a stable partner and stable, satisfying work. As I mentioned earlier, I think the chances of having one or both of those earlier is a way to understand what effective treatment should do. That doesn't mean that if it doesn't there at 2 years that the treatment isn't going well, but it does mean that if a patient isn't making progress in terms of a life outside of the therapy, both relationally and in terms of vocation, that you should worry about it, and you should worry about it with the patient, and you should raise the question, is this therapy something that is not working, or is there ways in which it can be improved? Not with the threat that you'll leave if they don't get a job, although even that's a debatable issue. I'm going to digress for a minute. In our outpatient and residential treatment program here, we insist that all patients, borderline patients, be working or in school at least part-time by 6 weeks to 3 months, or we suspend the treatment. My estimate is that 60-70% of people are working at least part-time or in school part-time within the first year. That's dramatically different than the natural course of the disorder. So that I do believe that clinicians can affect this, especially the work life, by their having expectations and, more importantly, by their insisting about how important it is for the person's future. If they want to have a stable partnership, they're not likely to get that unless they have some ability to take care of themselves and some source of self-esteem that does not depend upon the attention of their partner. So most people with borderline personality disorder are preoccupied with the idea that their life future depends upon getting an exclusive partner who's going to be devoted to them forever. That's never going to work. Work, having some kind of vocation where you get some satisfaction and where you learn the rituals of reliability and responsibility, puts you in a position where you can, at that point, become a satisfactory partner for somebody. You're not going to be a satisfactory partner if and when your life rises and falls with the vicissitudes of their feelings about you.
No, that's very helpful. So I want to move on to the next question. Our 16-year-old daughter has been diagnosed with BPD and depression. She's had 3 serious suicide attempts in under a year. She moved from a rigorous school program and a high GPA to being at home with supervision and taking online classes. A couple of trigger points seem to be around meeting daily expectations, for instance, schoolwork. More specifically, how do we talk to her when she doesn't fulfill reasonable and agreed upon expectations for completion of schoolwork? When we question her, she immediately gets defensive and shuts down. She has little to no ability to problem solve, plan, or take responsibility?
Well, I would assume that your daughter is ambivalent about growing up. And in the background of that, ambivalent about either school because she sees it as something that you're too invested in, or about school because she knows that her success in school is going to take her out of the house, and that she is facing, she's 16, 16. So she's at a point in her development where she's actively engaged with the prospect of becoming an adult and leaving childhood. She's in a transitional period where her brain is under active maturation, that she's riddled with lots of impulses, her identity is unsettled, and your attention to her homework and if absent is generally good. You know, neglecting it is not a good idea. But I can't tell from this whether she thinks you overvalue it at the expense of not being appreciative of how difficult it is or her inner experience. Those are good issues for examination, starting with your self-examination of what your family values have been and how they've gotten communicated. Is this a daughter who does or doesn't feel like you're interested in how she feels? Or is this a daughter who is very conflicted about growing up and leaving home? You can't necessarily ask her and get a straight answer on that, but you need to be thinking what's going on with her and invite her to explain as much as she can. It's often very difficult with adolescents. To help you understand her. Tell her that you're worried that your attention to homework may actually be aggravating her ability to do it. And so you want to be helpful and ask her for guidance. Now, she's can't remember if she's seen a therapist. I do some family meetings. Get outside input into what's going on with your daughter. And don't have it rest solely upon your wisdom and your intuitions.
And if I can just put in a plug for these parents, if they haven't learned about the skill of validation, we certainly have webinars on validation, and we have some upcoming webinars about how to more effectively talk with people who have borderline personality disorder, because sometimes they can just be very sensitive to what they perceive as rejection or criticism. And so I'm wondering if these parents are coming off as too critical, and then the daughter kind of freaks out and seemingly doesn't take responsibility because she interprets it as, you think I'm horrible and stupid and awful and lazy, and just a more effective way to communicate would help the situation.
I think that's a very thoughtful comment. Still, I'd be hesitant not to get some outside help. His daughter has had some suicide attempts or gestures, and that's usually a red flag that you need somebody else outside of the family to help.
Okay. So the next question is, my 25-year-old daughter never takes responsibility for her actions. Again, we're hearing that. Instead, she twists everything around and believes that I am the one who has wronged her. It's hard to deal with her misinterpretation of events and her lack of trust. When I try to get her to accept responsibility, she says that I don't care about her. This behavior is pushing us and other family members away from her. I worry that therapy won't be helpful because she constantly misinterprets things and has a very difficult time developing trust. How do we deal with this?
Echoing some thoughts that I conveyed earlier, you start out by questioning what, however unfair her allegations may seem. You start out with sort of a self-examining stance. How have I contributed to this? And starting out with that as a stance with your daughter, assume and take some responsibility on yourself that I know I'm not being successful as a parent, and it isn't because of my intentions. So I'd like your suggestions or help in terms of how I can become more trustworthy to you and somebody who can understand you better. Having said that, you say you think she'll bring the same problems to bear in a relationship with a therapist. I would not assume that at all. She might, but a therapist doesn't have the same kind of stake in the game that a parent does. They're likely, could usually presume, are going to have a little more distance, a little more dispassion. Their primary interest is in not whether the person is doing their homework or lying, but why they don't do that and how to help them overcome obstacles so that a therapist generally will be seen and treated differently than a son or daughter treats somebody within the family. Now, in this case, your daughter's 25 years old. These patterns are getting fairly consolidated during a period in her life, and she should be largely out of the house and getting a social network and a vocational identity that takes her away from your oversight and concern. As I've suggested before, repeatedly actually, daughter is 25, has borderline personality disorder. She ought to be getting the help of treatment, and she ought to be getting help in getting out of the house and out into the world. It's very alarming if she's 25 and she's not working or in school or both.
Good. So the next question, there are several instances where I'm just at a loss as to how I can be validating with our 16-year-old son. Most of these involve his behaviors which are either unsafe or in direct conflict with our values. Here are some examples. He frequently says that he plans to drop out of school. He's run away and been out of contact and unreachable for 20 hours, which resulted in a police report being filed. He, when asked to select a role model for a school assignment, he chose Hitler. He admitted to selling drugs and being held at gunpoint in a drug deal gone awry, but acted offended and complained that I don't trust him because now I routinely search his room for drugs. Any advice for this parent?
So many of these questions that I've been challenged by this morning have to do with parents who are trying to take care of a son or daughter, presumably that has borderline personality disorder, by themselves. Once again, here I'm struck. You're asking how to manage this. You're not asking a therapist. There's no evidence that a therapist is involved. You need some professional help with this. Now, I can give you some short answers, but those short answers are going to be just that. You are going to have to work on new ways of parenting this child. And this child needs to have a place in his life where he can talk about the problems that he's obviously having in growing up, his problems with your values, his problems with wanting to so clearly defy you and your values. That can take on a life of itself. That adolescent kids can be so intent on provoking and angering their parents that they, I almost said the wrong word, they could really screw up their own lives and then have a hard time recovering it. So this is not something to be watching carefully and trying to monitor by yourself. You need to get outside help on this.
Okay. So the next question, whenever my daughter has an incident or crisis, no matter whether it's accidental or not, she always blames herself. For example, she found out that she made a mistake in her work and sprained her ankle on the same day. She immediately became nervous, frustrated, mad at herself. She said, I'm stupid, I want to die, I'm not good enough, I'm such a mess. On these occasions, my mind goes blank and I don't know how to respond. What can I say to her?
Well, you start out by sympathizing with her. Yeah, I mean, it's terrible that bad things happen, and you can question whether that how much she should blame herself. But as Dr. Palmer suggested earlier, validation of the problem that you understand and feel for her is almost always a good first intervention. If in the background of this is a chronic issue with self-esteem and self-devaluation, that sounds more depressive than it does borderline. And once again, I'm just so struck by how time after time parents are presenting problems with their sons or daughters where they're trying to manage it without any professional help. And there are things you can do within a family that can be very important in changing the course of a son or daughter's evolving psychiatric illness. But it's almost always good, at least to get input for yourself about how to do that. So my suggestion about validation is a good idea. I don't have any doubt about it, but I doubt that that's going to be good enough if your daughter has chronic problems with self-esteem and self-derogation. If she truly wants to die, that's not something that the family can take care of. You need outside help with.
So we will move on. The next question, there's a lot of research out there that says borderline personality disorder is a treatable disorder from which individuals can reach remission and even recovery. Yet there seems to be somewhat of a mismatch between the clinical definition of recovery and the patient's quality of life is expressed through meaningful vocation and interpersonal relationships.
Yes.
What are your recommendations for helping clients achieve the deeper levels of satisfaction and wellness that stretch beyond clinical criteria and into the territory of human need? Or are you aware of any research or treatment options that address this tension?
Yeah. It's a good question, and it's worth noting that real recovery is not simply symptom remission, it's the acquisition of a rich and satisfactory life. And as Freud said a long time ago, the two pillars on a good life are satisfactory, stable relationships and satisfactory, stable vocation. Therapies for borderline patients neglected both of those. The good psychiatric management model of treatment actively incorporates that the idea of therapy is symptom remission is fine, but we aspire to and encourage patients to aspire to that the reason for having remissions of your symptom is it makes possible for you to get onto what we know is possible for most borderline patients, but the previous generation of treatments did not address. You can get satisfactory and lifelong partnerships, and you can find satisfaction and pride in a work life. We emphasize the importance of getting a work life as the first step towards getting satisfactory and permanent relationships. Our attention to this, I think, has made a difference. We have not documented that research. I now know that the other empirically validated treatments, recognizing that way we're very good for symptoms, but we're not very good for getting people into satisfactory lives, are now adopting more or less the same stance. The transference-focused psychotherapy, the most demanding and the most frustrating from a patient's point of view, now requires the patients to have full-time occupation before they'll take them into therapy. Now that bypasses a whole lot of things, but it also makes sense to me because if you're going to tolerate the frustrations of that kind of therapy, you're going to have some structures and supports for the rest of your life because that's a tough therapy. DBT therapists and MBT therapists are now getting increasing attention. They've not incorporated it into the manuals as to how the prescribed treatment works. But I know I'm in regular contact with practitioners and the leaders of these treatments. They're now incorporating an attention to getting a job as one of the important things for getting a good life and for ceasing someday to be a patient. So it isn't simply that our job is to get you to mentalize better. Our job is to get you to mentalize better so that you have better relationships and that you can manage the stresses in work. And that's really where the testing of these therapies is moving. But it's not entered into the research yet. I hope that answers this question.
No. I think that's a great answer. And I think it's a great point to end on, because unfortunately it is 11:30 and we've got to end today. But thank you very much, Dr. Gunderson. This was really helpful. For those participants who are interested in joining us for next week's webinar, we've got another one coming up next week. You see the slide on your screen, and you can register now if you're not already registered. And we've actually got the next two webinars listed, I'm sorry.